Madam, we are live now, shall we, sir?
Yeah.
So, good evening, Dr. Shuman, on behalf of Shield Healthcare, welcoming you all in today's session on medical management of lean PCOS. And our guest speaker is Dr. Priti, madam. Madam did her MBBS, DGO, DNBO, and Gynae. And she is a POXI certified pharmacologist, consultant gynecologist, Sayasa Hospital and Research Center, Ranchi. Madam is the Joint Secretary ROGS 21 to 23 and Executive Member Ultrasound and Imaging Society, ROGS, and Life Member of IMA and IFL. So this short introduction, I request Madam to take over the session. And meanwhile, I request all the participants for your active participation. And please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this emerging topic with Madam. So thank you very much, Madam, for your valuable time on our platform, and over to you, Madam, for further proceedings. Thank you very much.
Thank you very much, Dr. Suman, for your kind introduction. Good evening, everyone. Pranam to my seniors and love to the colleagues and the juniors. First of all, I'd like to thank SIL for giving me this opportunity to share my knowledge with you all. Now, the topic of discussion of today is medical management of lean PCOS. Next. PCOS is not merely a reproductive disorder, but an endocrinological disorder affecting the women in their reproductive years. Although hyperandrogenism and infertility that PCOS causes are distressing to the young women, its metabolic sequelae eventually affects the individual in terms of morbidity and mortality also. The incidence of polycystic ovarian disease is approximately 4 to 12% in reproductive age group women. Next. Causes and pathophysiology. The exact etiology, as we all know, is unknown till date, but PCOS often runs in families and appears to be the result of environmental and genetic factors. Other factors, although to affect the pathophysiology and phenotype of PCOS, includes a derangement in insulin secretion and sensitivity, lack of exercise and activity, persistent hormone imbalance. Next. Now coming to pathophysiology of PCOS, which is a very vast topic to discuss, but to summarize in this slide, the key pathophysiology in PCOS is insulin resistance. This insulin resistance causes hyperinsulinemia. All the three states of insulin metabolism is disturbed, like secretion, action, and clearance. Secretion of insulin is more because of increased glucose level in the body. Action is also decreased because of decreased insulin receptor numbers and also the resistance at the level of receptor because of decreased autophosphorylation at the level of insulin receptors. Insulin clearance is also disturbed because of acquired decrease in the receptor numbers and also the function of the receptors. The clearance is receptor based, so clearance of the insulin is affected. So there is hyperinsulinemia. Now, how this hyperinsulinemia affects the body and causes all these pathophysiology, that insulin affects many metabolic pathway in the liver. It causes decrease in sex hormone binding globulin production. It also causes increase in the production of glucose from the liver. So there is, as there is less of the sex hormone binding globulin production, so free testosterone is increased and also the free estradiol is increased. The hyperinsulinemia affects peripheral musculoskeletal system also. Here it causes decrease in utilization of glucose and thus leads to hyperglycemia. Hyperinsulinemia also affects the ovarian metabolism and the folliculogenesis. Because of hyperglycemia and hyperinsulinemia, the peripheral fats also causes increase in production of free fatty acid, cytokines, and PAI1. The increased free fatty acid, this is the precursor for androgens. So ultimately, this leads to production of more of the androgens in the adrenal gland and hyperandrogenism state. Now, what occurs at hypothalamo-pituitary ovarian axis is that there is enhanced GnRH pulsatile secretions and increase in LH pulse frequency as well as amplitude. Thus, there is tonically increase in the level of LH surge. But FSH is decreased in secretion because this occurs because the estrogen level is already free estradiol is more in the body. So pituitary receives this information and it produces less of the FSH. Thus, FSH and LH ratio is altered, more of the LH and less of the FSH. Now, to discuss in the level of ovary, what causes this PCOS feature in the ovary and what leads to this anovulation and all. Going into detail, in the ovary, there is dysregulation of CYP17 enzyme, which is the key enzyme for the production of testosterone. So, in the body, testosterone is increased LH, and the insulin, which is already increased in the body. This causes stimulation of theca cells and the stroma cells of the ovary, and ultimately increase in the level of androgen production. There is also defective aromatization of androgen to estrogen inside the ovary. So also there is increase in the androgen levels. And there is minimal in aromatase activity inside the follicles. So this leads to high intrafollicular androgen levels and thus arrest of maturation of the follicles, thus anovulation. So these are all follicles which cannot be ruptured, which have not ruptured, are arranged peripherally in the ovary, leading to the features what we get in the ultrasonography PCOS features of the pearl necklace appearance. Next. Now, insulin resistance affects almost 75% of the lean women and 95% of the obese women. Next. Now, coming to ovarian follicle development, this slide shows the phases of follicular development in intranatal and puberty and the postnatal phases. Intranatally, there are primordial germ follicles, germ cells, which are not specified for the ovarian specification, but in the absence of AMH, this primordial follicles gets the ovarian specification. Thus, germ cell ovary is formed. After birth, these makes the primordial follicles. And till puberty, there are millions of the follicles in the ovary, among which during the development, which is gonadotrophin independent in the beginning, there are many follicles which undergo atresia, but few follicles remains. The phases of follicles which are present in the ovary till puberty are mainly the primordial follicle till the early antral follicles. After that, when ovulation begins, which is the gonadotrophin dependent cycle, these are early antral follicles enters into the late antral follicles, and every month there is ovulation. Next. Now, criteria for diagnosis of PCOS. Rotterdams have given 3 features, among which at least 2, even if present, if the patient is diagnosed as polycystic ovarian syndrome. The features are hyperandrogenism, either clinical or biochemical, menstrual irregularities, and oligoovulation, means the number of cycles per year is 9 or less than 9, or the duration of the menstrual cycle is more than 35 days. And polycystic ovarian features in the ultrasonography, which includes the follicle number, of more than 12 of size 2 to 9 millimeter in the ovary, one or both, and the ovarian volume of more than 10 cubic centimeter. Next. Now coming to the clinical features of PCOS, which are mainly androgenic, gynecological, and metabolic. Androgenic features are alopecia, hirsutism, and acne. These all are mainly due to high in androgen level in the body. Gynecological features are irregular menses and ovulation and infertility. The metabolic symptoms are insulin resistance, obesity, increased chances of development of type 2 diabetes mellitus, and acanthosis nigricans. Next. There are mainly three types of phenotype of PCOS. Phenotype A, B, C, and D, which is dependent upon presence or absence of these three features: hyperandrogenism and hirsutism, ovulatory dysfunction, and polycystic ovarian morphology. In type D, mainly hyperandrogenism and hirsutism is absent. In type C, ovulatory dysfunction is absent. In type B, polycystic ovarian morphology is absent. And in type A, all the features are present. Next. Now on lean PCOS, what statistics says that 5% of all lean women have PCOS, among which 20 to 30% of women with PCOS are of average weight or lean. Women with lean PCOS often undiagnosed. Next. What is the definition of of lean? Obese is defined as BMI of more than 30, whereas overweight is defined as BMI of more than 25 but less than 30. Problem is with using BMI as criteria because no body composition info is there. Many lean women with PCOS have measurable body composition differences and separates out lean women. Less research on aspect involved in the continuum of PCOS since leans are a lower percent of women with PCOS. Next. There are criteria waist to height ratio also to confirm the lean patients. Less than 42 is extremely slim, 42 to 46 is lean and healthy, 46 to 49 is healthy and normal weight, and 49 and more is increased risk for insulin resistance and diabetes. In 2016, there was a study involved 754 women, the inference of which was waist to height ratio predicts insulin resistance in 71% of the women with PCOS. Right side, there is BMI calculator and waist to height ratio calculator. Next. What does insulin do in the body? It affects the blood glucose level. Blood glucose level is increased, which is stored for short term in the liver and for the long term in the fat cells. Again, these fat cells are because of insulin resistance. This cannot be this is not breaking down. So there is increased sugar stored in the fat cells. Next. Insulin resistance in lean PCOS. Depending on method of measurement, around 75% of lean PCOS women are insulin resistant, measured by markers such as HOMA insulin resistance and QUICkie hyperinsulinemic glycemic clamp, not by markers like HbA1c and fasting glucose. What about the 25% who are not insulin resistant then? Next. Insulin in lean PCOS. This is the graph, shows the insulin level with the time chart. Research suggests that many lean PCOS women have normal fasting insulin, but are more likely to have hyperinsulinemia after eating food. In the earliest stage with very lean PCOS, even post-meal insulin may be normal. In these cases, there is insulin hypersensitivity. Next. What is reactive hypoglycemia? This is the drop in blood sugar level 1.5 to 5 hours after eating food, due to which patients have increased hungers, and 50% of women with lean PC due to insulin hypersensitivity and or elevated insulin secretions, an early marker that often precedes the development of PCOS or insulin resistance. Next. Some women with lean PCOS have normal fasting insulin and don't secrete high amount of insulin when they eat. These women tend to have drop in their blood sugar after eating. They are actually hypersensitive to insulin. This diagrammatic presentation is showing insulin and sugar relation with time. Next. Insulin hypersensitivity causes hypoglycemia after meal, which causes increase in food intake to raise the blood sugar. And these all ultimately increases the excess energy stored in the fat and ultimately insulin resistance. These all are genetically controlled. What is the symptoms of low blood sugar in the patient is that shaking, sweating, anxious, dizziness, and hunger. These all symptoms leads to increased food intake to the patient. Next. Carbohydrate causes rise and then drop in the blood sugar. This is the diagrammatic chart which is showing the same. Next. It's harder to stay lean with PCOS, just as it's harder to lose weight in obese PCOS. Although women with PCOS have a higher BMI than control women, and overall composition of the women with and without PCOS showed no significant difference in the dietary intake. However, stratification by BMI revealed that lean PCO women with PCOS reported significantly lower energy intake than lean women without PCOS. Lean PCOS have lower calorie intake than other lean women's, harder to maintain weight. Next. Next. Lean PCOS women, how can you tell if you are insulin resistant? We need to look deeper if you are lean or average weight. The typical test for diabetes will show you a normal patient. What you need to test is fasting insulin level and fasting glucose level, which is very simple, cheap, and easy. Input numbers into HOMA-IR calculators. Right side, the HOMA-IR blood calculator have been shown, which you can also get in this website. There is HOMA in this calculator. You have to put fasting insulin level multiplied by fasting glucose level. If and the result if is 1, then it is a healthy in healthy range. If it's less than 1, means you are insulin sensitive, which is optimal. And if it is above 1.9, it indicates early insulin resistance. And if it is above 2.9, it indicates significant insulin resistance. So many studies uses a 2.5 HOMA insulin resistance as the cutoff. One study found that 47% of the lean women tested with PCOS were insulin resistant. Another large study on 6,868 healthy individuals found a cutoff of 1.7. Above this indicates insulin resistance. There is also one picky parameter, similar ratio based calculator may be more sensitive. Cutoff in this is typically less than 0.35 for insulin resistance. Next. Lean PCOS women, how can you tell if you are insulin resistant? You can do a 2 or 4 hour insulin glucose tolerance test. This is similar to the glucose tolerance test, but here insulin level is also measured, which shows if you make too much insulin after eating or if it stays high too long. It can detect reactive hypoglycemia also. Next. This diagram is showing fat cell dysfunction, its inflammation, and changes at the circulatory level. Next, insulin normally causes capillary growth, but in PCOS, this is impaired. Lower circulation to the muscles and tissues contributes to insulin resistance. Insulin resistant level in the blood vessels a long time before it can be detected in the muscle, liver, or fatty tissues. Lean women with PCOS may have poor circulation as a result of poor capillary function. Next, right side, this diagram is showing the normal hypothalamo pituitary ovarian axis. Higher the LH to FSH ratio than in the classic PCOS. This has been found that in lean PCOS, there is higher LH to FSH ratio. The more lean the women, the higher her LH to FSH ratio will be. And it should be checked on cycle day 2 or day 3 if she is having menses. Next, what occurs at the acquired system in the lean PCOS? It has been seen that they have a high pain threshold compared to women without PCOS. There is higher beta endorphins, and beta endorphin stimulates the LH surge release also. That's why there is a high LH surge in this patient, may be related to mood disorders. Next. Now, adrenal androgen excess in PCOS. This diagram is showing the hypothalamus, pituitary, and adrenal axis, where more of the androgens are being produced because of more in corticotropin releasing hormone secretion. There is high level of DHEAS, more common in lean PCOS. It helps with metabolism and makes being lean easier. DHEAS reduces with age, so a higher level in an older woman is unusual, even if not above the range. Next, way to help lean PCOS. Keep her blood sugar level stable. Ask her to exercise to make her lean muscles stable, resistance training, improved insulin delivery to the muscle tissues. Follow diets that modulates insulin secretion after meal, like base meals around protein sources. Avoid carbohydrates alone. Avoid carbohydrates with fat alone. Stress reduction is the key in the management of lean PCOS. Mindfulness, prayer, yoga, meditation, and ample of sleep can help these lean PCOS. Next. This is the diagnostic algorithm for PCOS. Features of hyperandrogenism, the menstrual and the ovulatory dysfunction, as I have already explained, and the ovarian morphology. These have, if we found at least two of these, we will suspect of PCOS. But we have to exclude the other diseases also, like common conditions, thyroid disease. TSS should be done as the baseline investigation. Late onset congenital adrenal hyperplasia. In this, high early morning and or post acetylcholine ACTH stimulated 17 hydroxyprogesterone level, and hyperprolactinemia, where the prolactin levels are raised. And less common diseases are like pregnancy, hypothalamic amenorrhea, primary ovarian failure, androgen secreting tumors, and the Cushing disease. Next. Management algorithm for lean PCOS. Main is the lifestyle modification. The first and prime management is to weight maintenance and avoidance of weight gain through dietary modification. Consumption of ample of vegetables, fruits, vitamin D, calcium, and herbs. And ask her to do regular exercise and yoga and meditations. If these are inadequate to help her out, then add on metformin or myo-inositol along with additional management for following conditions when necessary. If there is hirsutism, it can be managed mechanical like saving electrolysis and laser, and also pharmacological treatment like combined OC pill and androgen receptor blockers and finasteride. If C have menstrual dysfunction, it can be controlled by progesterone alone or with combined oral contraceptive pills. If C is having acne, then topical benzyl peroxide and or retinoids and oral antibiotic like doxycycline will work. And if this is very severe, then isotretinoin can also be given. If C is suffering from infertility, pharmacotherapy like clomiphene citrate and or gonadotropin and surgery like bilateral or unilateral laparoscopic ovarian drilling can be done. And if at all are not functioning, then in vitro fertilization is the last option. Next, metformin therapy. Uh, it reduces the serum glucose level by improving glucose uptake and use in the periphery and reduction of hepatic glucose output. Metformin use was more successful in restoring menstruation. It has been seen in 55% of the lean women, and it improves the ovulation in 45% of the lean women with PCOS compared with their obese counterparts. Remember the low risk of hypoglycemia in this anovulatory women undergoing metformin therapy. Next, myo-inositol can help these lean patients by we can give them 3 grams per day of myo-inositol appear to have a positive effect on lean PCOS women. Treatment led to reduction in the luteinizing hormone, adrenal androgen levels, and high sensitivity with the C-reactive proteins with a role in inflammation and facilitated insulin tolerance. Myo-inositol improves insulin resistance by acting as a messenger for insulin signaling, subsequently increasing the uptake of glucose in the periphery. The hormonal profile and the ovulation is also restored because there is decrease in the luteinizing hormone and androgen level in these PCOS women. Next. Vitamin D status. It has been seen that low vitamin D is associated with insulin resistance in PCOS. Next. Now to summarize the lean PCOS and its management, metabolic, hormonal, and hematological derangement exist in the lean PCOS also. Insulin resistance is inherent in PCOS regardless of their BMI and should be managed as early as possible. Lifestyle modification, restoration of ovulation with the use of pharmacology can provide symptomatic relief to these patients. Thank you very much.
Thank you very much, madam, for this nice presentation. Just give me 1 minute time, madam, to check if any question is there.
Yeah.
So, madam, the first question is, what would be the ideal treatment in case of this lean PCOS?
Hello.
Yes, madam.
The sound is not coming properly. Not audible.
Am I audible, madam?
Oh, your sound is not properly coming. Your network is not good, I think.
Madam, am I audible?
Yeah, hello.
Am I audible, madam?
Yeah.
Ma'am, what will be the ideal treatment in case of this PCOS management, lean PCOS particularly?
First, we have to try with the lifestyle modification and the food management. If at all this is not working with the patient, then only we will go for the pharmacological therapy. And as I have already told, the pharmacology will depend upon the patient's symptom, what the patient is suffering from. The base of the treatment is either metformin or myo-inositol. These two agents are actually insulin sensitizers. So we can go with these treatment, and also symptomatic treatment, like if she is having acne or she is having like hirsutism or infertility, we can manage those elements.
Thank you, madam. And ma'am, another question, as there is some insulin resistance also. So what means metformin or some other drug has to be given in case of lean PCOS?
Yeah, we can give myo-inositol also in these lean PCOS patients, like 3 grams per day. We can provide to the lean PCOS patient. This will improve the insulin resistance in the body and also decreases the LH surge in the body. So it improves all the means imbalance in the hormonal level and insulin level, hyperandrogenism state and the hyperinsulinemic state. These both will be controlled.
Thank you very much, ma'am.
Thank you.
So, madam, I could not find any other question right now. So, if you allow me, then we can conclude this session for today.
Yeah, of course.
Thank you
So,
so
thank
much.
you very much, madam, for your valuable time in our platform and for such a nice discussion on this emerging topic as well. And in future also, we look forward for some academic session with you, madam, in various other topics. So, thank you very much, madam, once again for your valuable time on Shield Connect, and have a good day, madam. Thank you very much.
Thank you.
Thank you, ma'am.
Thank you.